Get started. Okay. Okay, so most of you probably know me. I'm Shad. I'm one of the first-year pulmonary critical care fellows, and today I'll be talking about pulmonary physiology in pregnancy. So it was a big learning curve for me when I started reading about this topic, because pregnant patients do make me nervous, as I feel I don't have enough knowledge to, given change in pulmonary and cardiac physiology. So I think this is a good topic for me to learn even for myself. So the factors that affect cardiopulmonary physiology in pregnancy, few of them are listed here. So it's mainly driven by hormone changes during pregnancy. You have the mechanical effects of the gravid uterus itself, and you have the circulatory changes that happen during that time too. So we'll focus on the respiratory changes first, and then I'll briefly talk about the cardiovascular changes, and then we'll go over a few cases. So let's talk about the upper airway changes. So during pregnancy, you would expect to see mucosal changes in the upper airway, and that includes hyperemia, more edema. Because of the hyperemia, you have the leakage of the plasma into the stroma of the mucosa. You have glandular hypersecretion. And all of this is during pregnancy is related to estrogen and placental growth hormone. However, when you see pregnant patients with these changes, you still have to consider other etiologies. You still have to keep the other etiologies in mind, which includes your allergies, smoking, infections, sinusitis, and chronic vasodilatory topical medications that they might be using. So all of that still has to be considered. So let's start with the case. So 31-year-old female at 32 weeks gestation complains of nasal congestion. She first noticed it early in her pregnancy and reports that it has gotten worse now. She has no previous history of allergies, denied having any fever, chills, or any sinus pain. So what do you think is going on with her? She's pregnant? Okay. That's a good observation. Do you think it's something to worry about? Do you think you think it's physiological? Yeah. So there's a entity called rhinitis of pregnancy. It's defined as nasal congestion during the last 6 weeks or more of pregnancy, and it resolves within 2 weeks of delivery. And when they have these symptoms, you want to make sure they don't have any respiratory tract infections or any other allergic cause. So if you can't find any of the other etiologies and they have these symptoms, and postpartum within 2 weeks, if it resolves, that's rhinitis of pregnancy. Now, why is this important? So there's studies that looked at the effects of rhinitis of pregnancy on maternal and fetal outcomes. So usually, like we talked about, when you have upper airway changes, nasal congestion, it can cause nasal obstruction, and patients can have snoring and sleep related breathing disorders, and that can lead to hypertension, which can cause preeclampsia, may cause growth retardation. However, the correlation and the causation of this causing growth retardation is controversial. So something to keep in mind, it does have implications. Next, we'll talk about chest wall changes. So this was a study by Lamoro et al. They essentially looked at, it was a case control observation study. And essentially what they did was looked at first-time pregnant women above the age of 18 and compared them to the control group, which was the non-pregnant women. And essentially looked at all these respiratory changes. What they found was in the graphs on the left, from A to G, you have the timeline of pregnancy as the x-axis. So T1, T2, T3, they are essentially representative of the trimesters. And the y-axis varies based on what graph you're looking at. So the first graph looks at the AP diameter as you go through pregnancy, and the gray area, as well as that gray dotted line, that's essentially that represents the control group, essentially. So the dashed line essentially is the median, and the gray area is the interquartile range. So as you can see, the AP diameter, it increases as you go through pregnancy. And all these changes were statistically significant. Now, if you take a look at graph G, that looks at the costal angle. Now that is schematically presented in the diagram on the right. So costal angle essentially is the angle between your lower ribs and the xiphoid. So if you look at the subcostal angle, as you see, as the woman progresses from T1 to T2 to the third trimester, the subcostal angle increases, and in this study, the angle on average increased from 68.5 degrees to about 103.5. The medial lateral direction, you see increase in that parameter as well. So why do these changes occur? You have the enlarging uterus that needs to be accommodated. So that's one of the reasons. You have the increasing maternal weight, and then hormones. So the primary hormone that drives a lot of these chest wall changes is called relaxin. It's released by the ovaries and the placenta. And essentially it's the same hormone that causes the pelvic ligaments to relax and is likely contributing to the chest wall ligament changes as well. These anatomic changes that we talked about usually peak at week 37 and usually normalize by 24 weeks postpartum, except one of the parameters. Does anybody want to take a blind guess or an educated guess? So it's a subcostal angle. So the subcostal angle doesn't come back all the way to normal. It only comes back to about 20% compared to baseline. So it doesn't go all the way back to normal. So yeah. Yep. So let's talk about the respiratory. So we talked about the chest wall. We talked about the upper airway. Let's talk about the respiratory muscle function. So usually with the inspiratory muscles, you don't see much of a change, meaning their strength is usually preserved during pregnancy. What you do see is the diaphragm excursion changes by 2 centimeters. What that means, the diaphragm excursion is essentially movement of the thoracic diaphragm at maximum inhalation and exhalation. So that increases by 2 centimeters. And this is thought to be secondary to increased apposition of the diaphragm against the chest wall. So it's more stretched and more attached to the chest wall, and that's why the excursion increases. So all of these changes happen to accommodate for the increased tidal volume and minute ventilation that you notice in pregnant women. And we'll talk about it in slides coming up. With regards to the lung function, so things we'll talk about under lung function would be the static lung function. We'll talk about the spirometry, airway resistance and conductance, and diffusion capacity. So let's talk about lung function, static lung function. So in pregnancy, there's an average 4 centimeter diaphragmatic elevation. So there's cephalad displacement of the diaphragm. You have the downward pull of the decreased downward pull of the chest wall because of the abdominal contents and the gravid uterus. And you have decreased chest wall recoil. Now, what determines FRC? So when you're doing this, when you're doing PFTs and you look at FRC, the two forces that contribute to FRC, one would be the opposing forces of the chest wall outward and downward. And the opposite force would be the lung recoil or the compliance. Now, during pregnancy, the compliance of the lung doesn't change. So the other factors, which is the chest wall changes and the upward displacement of the diaphragm, they will lead to decrease in your functional residual capacity or FRC. And when you see reduction in FRC essentially comprises of two volumes, right? It's your expiratory reserve volume and your residual volume. So both of them go down during pregnancy. Most of the other parameters, you don't see much of a change. Your FVC goes up a little bit because your residual volume has gone down, but your total lung capacity doesn't change. The decrease in FRC, it's significant. It's about 20 to 30%, and that relates to about 400, anywhere between 400 to 700 cc's. So it's a significant change. So what other condition that you know of is associated with reduction in FRC?
I'm just pontificating in my head because like all of a sudden you have you're expanding as much as you can, you don't have as much reserve.
Right. So think of the two forces we talked about. So lung volume reduction, maybe it has to do more with your lung compliance, right? But obesity, right? So how would you obesity will cause your FRC to go down? But how would you differentiate obesity from pregnancy? What's the other value that is different? When you look at the PFTs, you can tell if it's obesity or if it's pregnancy. ERV goes down. What happens with the residual volume though? It goes up because of air trapping. So your residual volume goes up in obesity because of air trapping, but it goes down in pregnancy. So.
I've integrated too many pregnant ladies during this coronavirus pandemic.
Yeah.
I'm staying for this lecture.
So let's talk about this question here. So 31-year-old at 25-week gestation, history of mild intermittent asthma, presents with dyspnea, has the following values on spirometry. It's a made-up case, so FEV1 60%, FEV1 over FVC of 65% predicted, FVC of 77% predicted. What's the most likely explanation for the above spirometry results? Asthma or pregnancy-related changes? Just take a guess. Asthma? Pregnancy? Okay. So it usually spirometry doesn't change during pregnancy. Your FEV1 over FVC ratios, they do not change with pregnancy. So if you see abnormal spirometry during pregnancy, think of pathologies. It's usually not related to pregnancy. So think of pathologies. So asthma, yeah. Okay, so one other thing to keep in mind, so with regards to the airway resistance, so you have these hormonal changes that cause bronchodilation. So your progesterone, the relaxin, progesterone, they cause bronchodilation, but then you also have this nasal congestion, more upper airway changes that cause more airway obstruction. So you have these counteracting forces. So essentially the resistance and the conductance, the airway conductance during pregnancy doesn't change much. There's no significant changes because of these counteracting forces. Let's talk about the diffusion capacity. So the diffusion capacity usually goes up during the first trimester. So it essentially peaks in the first trimester. And does anybody want to take a guess at why? Yeah, so increased plasma volume, right? And increased cardiac output. And then it drops during around 24 to 27 weeks and plateaus out. So if you look at the duration of pregnancy, there's no significant change in DLCO. It goes up, then goes down, and then plateaus out. So it kind of stays unchanged. The decrease that you see in the DLCO, so the factors that increase it are, like you said, like Hafsa said, increased plasma volume, increased stroke output. But what happens is when the plasma volume goes up, you don't have an appropriate increase in the RBC mass. So you see some increase in your RBC mass, but it's not proportionally increasing as compared to the plasma volume. So you have some what's called hemodilution and anemia of pregnancy. So that's why your DLCO is low. Now, with exercise, as you would see in non-pregnant patients, the DLCO would go up. Why does DLCO not increase in supine position? Usually you would notice some increase in DLCO in pregnancy. Usually it should go up a little bit in non-pregnant patients. Right, so it's a mechanical effect, right? So the mechanical effects on the IVC will decrease your preload. Now, talking about ventilation and gas exchange. So this is where I think I would spend a little bit time during this lecture. So during pregnancy, the minute ventilation goes up by almost 50%. So that's a significant increase in minute ventilation. However, one thing to keep in mind, and even for boards, the increase in minute ventilation is driven by increase in tidal volume and not by the respiratory rate. So the respiratory rate doesn't change much. It changes by maybe 1 or 2 breaths per minute, but that's not a significant change. Most of it is driven by the increase in tidal volume. Now, when the minute ventilation goes up, you also have, as you can see in the graph below, the oxygen consumption goes up, the VO2 that you would see on your CPET studies, that goes up too because of the increased maternal demands, the fetal demand. So there's more oxygen consumption. There's more CO2 production because of the increased metabolism. However, the increased minute ventilation is, again, in proportion to the oxygen uptake and basal metabolism is significantly higher. So you have with your PaO2 and SaO2, so your arterial and alveolar oxygen content will go up because of this disproportionate increase in the minute ventilation and the O2 consumption and CO2 production. So that increased tension of oxygen is what's it's what helps drive the oxygen through the placenta. Other thing to remember is with the hyperventilation in pregnancy is driven by progesterone and augmented by the underlying metabolic state of the patient. So the way the progesterone drives the hyperventilation, the postulated theories are that it probably decreases the threshold and increases the sensitivity of the central ventilatory receptors to CO2. So what happens with gas exchange during pregnancy? So like we said, because of hyperventilation, your PCO2 goes down. With decreased PCO2, your pH will go up and you have respiratory alkalosis. And if you look at the alveolar equation on the right, you can see that by drop in PCO2, your alveolar oxygen goes up, right? Because your barometric pressure, the partial pressure of water, all of that is unchanged, right? So the only factor that's changing is the PaCO2. And we said that goes down during pregnancy, so it'll drive the alveolar oxygen up. So that's why their PO2 is usually higher. And these are the ABG values. So if you have a pregnant patient and you're testing an ABG, their PCO2 being 37 is normal for their state. They don't have to be at 44. And the serum bicarb for pregnant patients, because of that compensation to that respiratory alkalosis, is on the lower end. So it's anywhere between 17 to 18. So these are something to keep in mind when you have patients in the unit and you're checking the ABGs. Now, we said the PaO2 goes up because of that decrease in PaCO2. However, despite that increase in PaO2, remember we said the FRC goes down, so their oxygen reserve actually goes down. And considering the oxygen consumption, if you look at the high PO2 and the use of oxygen, they actually don't have much of a reserve. So when you have pregnant patients in the unit and you're trying to intubate, this would play a role because you want to make sure you pre-oxygenate them really well before you tube them, because they don't have as much of a reserve as compared to non-pregnant counterparts. So let's talk briefly about what happens to the cardiovascular system. So like Hafsa mentioned earlier, the blood volume, there's expansion of the total body volume. There's about 40% increase in the plasma volume, about 20 to 30% increase in red cell mass. And that's what I was describing earlier. Because of this mismatch, so they're not proportionally increasing, and that's why you see hemodilution, and that's what's labeled as anemia of pregnancy. So you'll see their hemoglobin concentration go down during pregnancy. cardiac output, like we mentioned, cardiac output goes up. It usually starts increasing around 5 weeks of gestation, and it peaks at about 25 to 32 weeks and increases by 50%. So that's about approximately 2 liters a minute. Now, the parameters that contribute to the cardiac output are your stroke volume and the heart rate. So the increase in heart rate goes up. So it's about 20%. However, one thing to remember is the contractility doesn't change during pregnancy. So the contractility of the myocardium doesn't change. So the chronotropy changes, the inotropy doesn't change. And the stroke volume essentially goes up because your plasma volume has gone up and your afterload is decreased because you have more vasodilation during pregnancy. So that's why your stroke volume goes up. And in regards to the central venous pressure and the pulmonary vascular changes, so you don't see much of a change in their central venous pressure, pulmonary capillary wedge pressure. You do see vasodilation because progesterone affects all vessels, right? So you do see some pulmonary vascular resistance drop, just like your SVR drop, but not much change in any of the other parameters. So this is just a graphical representation of what we just talked about. So you see the cardiac output go up starts going up at around 5 weeks, peaks at about 24 to 32 weeks. And then your systemic vascular resistance goes down and the mean blood pressure essentially not much change, maybe a little bit of a drop, but not significantly changed. So we looked at the normal physiology. So it's important to know what the normal is before you start seeing pathologies, right? So dyspnea, it's a very broad topic. Talking to Dr. Ouellette, it's a big topic. It's a presentation by itself. You can spend hours talking about dyspnea in pregnancy and how to work it up and what the potential etiologies are. But we'll talk about a general layout, and I'll try to focus on just a few topics related to dyspnea in pregnancy. So 60 to 70% women experience dyspnea during normal pregnancy. So this is physiological dyspnea of pregnancy that I'm talking about. I'm not talking about pathological causes. It usually starts in first to second trimester. The frequency increases during the second trimester, and then it stabilizes during the third trimester. So if you look at the bar graph down there, the blue part essentially represents dyspnea with climbing hills or multiple flights of stairs. Green is dyspnea with just one flight of stairs. So essentially green is dyspnea with even less exertion, and red is dyspnea with any exertion. So as you can see, the frequency increases during the second trimester, and then it kind of plateaus out. So one thing I wanted to mention is, the reason why pregnant women feel so dyspneic is just because they have increased awareness of their, altered breathing. Their minute ventilation has gone up, their tidal volume is increased. So it's just increased awareness of their changed breathing pattern. That's why they complain of dyspnea. Again, I just want to emphasize this is just physiologic dyspnea that I'm talking about. Okay, so we'll have a few cases now. So this is a 28-year-old female, G1P0 in her 26th week of pregnancy. She presents with shortness of breath, pleuritic chest pain after a recent plane trip. No other past medical history. She's tachycardic, heart rate of 110 per minute, normal respiratory rate. Blood pressure is 108/60. Lungs are clear to auscultation. Cardiovascular exam shows tachycardia, 2+ lower extremity edema on the left and 1 on the right. No tenderness, no redness or palpable cords. CBC, CMP are within normal limits. Chest X-ray is normal. What would be a next step in management? Doppler. Anybody has anything else they would?
No, that's not the right answer.
You want to do the D-dimer? Okay, so D-dimer? Yeah, so So you would do I didn't highlight it, but essentially the right answer is lower extremity Dopplers. The reason we don't do D dimers, the reason we don't do D dimers is in this case, first of all, your pretest probability is pretty high, right? So even if she wasn't pregnant, you still won't do it. Now, if you still had an intermediate probability, if this was not a pregnant patient, you could have gone with a D dimer maybe. In pregnancy, the D dimer is falsely elevated. So it's elevated in pregnancy, you can have false positives. So it's not very reliable. So usually during my read, I didn't come across any circumstances where you would actually check a D dimer during pregnancy. Anytime you have any thromboembolic case during pregnancy. So lower extremity Dopplers would be the right answer here. So let's talk about this case, and then we can talk about thromboembolic diseases in pregnancy. So 23-week pregnant mother presents to the ED with dyspnea, leukocytosis, and fever. Vital signs are significant for a temperature of 99, tachycardic to 134, soft blood pressures 90/60, and oxygen saturation of 90% on 6 liters nasal cannula. Chest X-ray shows elevated diaphragm bilaterally. D dimer is positive. They decided to check a D dimer. It was positive. Subsequent ultrasound of lower extremity showed a clot in the superficial femoral vein on the right. What is your next step? Superficial femoral vein. So how many people say VQ scan?
The thing is, in pregnancy, you can have a mismatch anyhow.
Okay.
So it's like, how would you know that the mismatch isn't due to like a PE versus just like?
Okay. So what do you want to do, Crystal? You don't want to do a VQ scan. You told me that.
Well, no, hold on.
Anybody else can help her out. CTPE?
It's superficial, it's not as, but she's hypotensive tachycardia. Not hypotensive. Can we do like a bedside ultrasound for like our?
That's not an option. Bedside ultrasound is not an option. Okay, how many people say 1? Just raise your hand. How many people say 1? Okay. Start antibiotics?
No.
CTPE?
No.
4 people, okay. And then IV heparin? Okay. Okay. So IV heparin is actually the right answer. So why is IV? I just put this, it's a trick question. I just put it in there to see if you guys are paying attention. So superficial femoral vein is actually a deep vein. It's not a superficial vein, right? It's a DVT. So yeah, so superficial femoral vein is actually a deep vein. So once you have a diagnosis of DVT, you So it's just a trick question. I just want to make sure everybody was awake. But essentially, you already have a diagnosis of DVT with that ultrasound, so you would just heparinize her.
Isn't it like the lower or the smaller the peaks are for the fetus like first trimester? Isn't that like higher risk of brain bleed or no?
No, you would still treat, and we'll talk about the algorithm. Yep. So this is an algorithm that was published by the American Thoracic Society. It's a guideline that they published specifically for thromboembolic disease in pregnancy. So if you have a suspected PE, what you want to look for is like symptoms first, because keeping one thing in mind, you want to be as minimally invasive as possible and least amount of radiation as possible, right? So you look at the leg symptoms. If they have leg symptoms, you just get CUS, essentially compression ultrasound, so essentially your Dopplers. So if they have symptoms, you would get a Doppler. If it's positive, you treat it. If they don't have leg symptoms or your Dopplers are negative, you would get a chest X-ray first. And then based on what the chest X-ray looks like, the reason we get the chest X-ray is to see if it's normal or not. If it's normal, then you can do a VQ scan. So when we do the VQ scans in pregnancy, they should be normal in normal pregnant patients, unless they have some kind of acute perfusion defects. So it's just like non-pregnant patients. So they don't have, when you talk about VQ mismatch, they don't have a VQ mismatch significant enough to like affect the VQ scan. So you should still be able to do a VQ scan in pregnant patients. So if the chest X-ray is normal, you would do a VQ scan. And if that's positive, you treat it. If it's negative, you stop. A lot of times, if it's indeterminate, then you're stuck with doing a CTP. So it's not that you can't do a CTP. You can do a CTP in pregnant patients, but make sure you try your other modalities first that are, less radiation, less invasive. So let's talk about this case. So 25-week G1P1 woman is admitted with premature contractions, no past medical history. They gave 4 grams of mag sulfate with progressive loss of deep tendon reflexes, just so you know, that's what they're looking for. So that's what the goal is. Following persistent contractions, the IV terbutaline is given. Over the next 12 hours, she gets progressively short of breath and requires 40% by a non-rebreather. She's tachycardic to 110, blood pressure is 108/34. Chest X-ray shows some vascular congestion, signs of fluid overload. What is your next step? Stop the terbutaline. Anybody else? You can give Lasix, but so you want to give Lasix?
No, I'm saying. Why am I sitting in this corner over here? I need to move over there.
Well, wait, you question me, I counteract with another question. Okay, so D, stop terbutaline. Okay, yeah, so that's the right answer. And why would you stop? What's terbutaline? Yeah, it's a beta agonist, a beta mimetic, right? So what happened and what does that do? Why did it cause these symptoms? So it's actually more vasodilatation. It increases the permeability of the plasma membrane, and you have more fluid shift out of the capillaries. So yes, it causes a little bit of tachycardia, but it's mainly the vasodilatory effects that causes. So there's an entity called tocolytic induced pulmonary edema. So that's what this patient has. So it causes vasodilation. Yep. So these are some of the differentials. So if you have a pregnant patient come into your clinic with dyspnea, it's not an easy diagnosis to deal with. Talking to Dr. Lett made me realize how complex some of these patients can be. And the reason why these patients are so complex is because you're limited with what you can do, what kind of medications you can give them, and what kind of testing you can do with them. So these are some of the common differentials you should keep in mind. Asthma, thromboembolic disease, pulmonary edema, tocolytic induced pulmonary edema, like we saw in the previous case, DKA, anemia in general, any valvular dysfunction, arrhythmias, and then your usual etiologies that you would suspect in non-pregnant patients as well. So let's talk about this case. So 19-year-old G1P0 woman with asthma comes to you to see you in the clinic during her second trimester. She is requesting a refill of her albuterol. You further ask her questions and find out that she's been using her albuterol inhaler up to 4 times a day for the past 2 weeks. And this is actually her 3rd prescription for the month. What is the next best step? ICS? Okay.
I actually thought, because she's second trimester, so she would have a more gravid uterus, would she not be able to do her like the same type of technique and get her tidal volumes?
Okay, so I have 3 and so possibly 3 and 4.
3 minutes ICS, but like maybe she's not having good pulmonary excursion to do everything else.
So let's go back to the physiology that we talked about recently. So what did we say about the total lung capacity in pregnant patient? Right. What's the only factor that changes during pregnancy that might impair gas exchange? So residual volume and your FRC, right? Your ERB, RB, and FRC. None of that would change that, yeah. So no, that's a valid question. So one, you would never do one because even in non-pregnant patients, right, it increases mortality. So you wouldn't do one either way. You would not refill her albuterol because she's clearly not controlled, right? So you would have to escalate her therapy. We talked about why 3 is not the right answer, right? Unless she has, she's not somebody who's old that might have like problems with dexterity or things like that, that would affect her technique, right? So, and then why not theophylline? So you can use it if you had to as an alternative, but ICS is better than TF. So if you had to, somebody who could not do ICS or already is on ICS, if you had to, you can do, and we'll talk about it in the next slide. So let's talk about asthma. So why is asthma control so important in pregnancy? And you'd see that even, there's tons and tons of research out there, looking into asthma control in pregnant patients and looking at maternal fetal outcomes in these patients. So there was a study by Enrique et al. And essentially what they did was study the effect of maternal asthma and control of asthma during pregnancy on the perinatal outcomes. So it was a pretty decent sized study. They had about 140,000 patients, 6% of which had, about 6.4% had asthma, and they looked at the demographics and controlled them for race and age and smoking, their socioeconomic factors. And what they found, which is depicted here in the graph, is actually uncontrolled asthma relates to lower birth weight. And this was a clinically significant, statistically significant finding. So what you see, the first category of the bar graph is asthma, patients with asthma who did not have any exacerbation, no hospital visits or ER visits. So just having asthma itself, on average, reduces the birth weight by about 38 grams. So just having asthma puts the patient at risk and the fetus at risk of having low birth weight. Now, if they have uncontrolled asthma, so if you look at the extreme right bar, essentially it's somebody who has very poorly controlled asthma, had more than 2 exacerbations requiring steroids, and the average drop in birth weight is about 60 grams. So, and these outcomes are clinically significant. These outcomes have clinically relevant outcomes for the baby. So that's the reason why we focus so much on asthma control during pregnancy. Now, asthma and pregnancy, always remember it's a rule of third, right? 1/3 will see improvement in asthma during pregnancy, 1/3 will see worsening of their asthma during pregnancy, and 1/3 have no change, essentially. In the same study, they looked at, after the forest plot graph here, looks at the different parameters, that the different variables that they looked at in regards to the maternal outcomes and the fetal outcomes. And essentially, if you see birth weight, we already talked about, which is the second one. And then the hypertensive disorders, there's a significant correlation with uncontrolled asthma and essentially hypertensive disorders of pregnancy, including preeclampsia. The only variables that didn't show much difference was birth defects and membrane disorders. Not much, preterm birth. So birth defects and preterm birth didn't show any clinically significant correlation with control of asthma. this was another study that was published in NEJM, and essentially it's kind of a review of asthma and asthma control and how to assess asthma in pregnant patients. And this is the the steps of asthma therapy that they recommended. So as you can see, if they're well controlled, if they're, don't, essentially one is they don't have any asthma whatsoever. Or they're using their albuterol once in a blue moon. And then your step 2 would be to add the inhaled corticosteroids. Your step 3 would be to add medium dose inhaled corticosteroids. So you're essentially not adding a LABA till you get to step 4. So you optimize your inhaled steroids first, and then you start adding the beta agonist. And like we discussed earlier, so if you had to, you can do theophylline, you can do cromolyn, but these are not superior to the inhaled corticosteroids. And like we said, it's albumin bound, like Hafsa mentioned. With pregnancy, you want to avoid them as much as you can, but if you had to, you can add them. They're not completely contraindicated. And the way you would assess them, so once you put them in appropriate therapy, when you assess them, essentially you're looking for, are they well controlled, meaning less than twice a week use of their inhalers, less than twice a week symptoms, and less than 2 nights a month of symptoms. And then your poorly controlled asthma on the other side, where they have almost daily symptoms, they're using their inhaler almost every day or several times a day, and they're frequent, almost every other night they wake up with symptoms. So this is where I'd like to end the lecture. So the key points to remember is you have significant anatomic cardiopulmonary changes that occur during pregnancy, and these are essentially to meet the increased metabolic demands. Your key cardiovascular changes are increase in plasma volume, increased cardiac output, and decrease in stroke volume, and decrease in systemic vascular resistance, sorry. And the key respiratory changes that you would see are the chest wall changes that we talked about. Subcostal angle doesn't come back all the way to baseline even after pregnancy. The diaphragmatic alterations, and then decrease in FRC without any change in total lung capacity. And then increase in minute ventilation, and key to remember is it's driven by increase in tidal volume and not the respiratory rate. And then otherwise no significant change in spirometry, DLC, or oxygenation. And asthma, remember, rule of thirds. And then it's important to control asthma in pregnant patients because it has poor outcomes, but poor outcomes associated with uncontrolled asthma. I will be happy to take any questions. Yeah.
So if we have an integrated pregnant patient, should we be aiming for higher tidal volume? Even though their total lung capacity has changed because they have that, especially if they're in the third trimester or something like that, should we be aiming for higher?
So it depends what the underlying physiology is, right? If they're ARDS, then you would have to weigh your risks and benefits. So it'll be dependent on what the underlying pathology is, why they're intubated. You would follow, if it's ARDS, essentially you can follow the gas. You know what the normals are different for pregnant patients, but essentially it'll be driven by your underlying pathology. Yeah. Anything else? Any other questions? Okay, there was a question from Aditya. Is there increase in PO2 over SaO2 threshold for acute hypoxic respiratory failure in pregnant patient? And Dr. Ouellette said, recommend using a PO2 target on a ventilator to be a little higher than normal, usually PO2 more than 70, and PCO2 target should be about 30 to 32, since we know they have underlying respiratory alkalosis. Okay, I don't see any other questions.
Yeah, good.
Good job.